So I want to welcome everyone to our educational program tonight, Cancer-Related Fatigue with Dr. Jessica Engel. Dr. Engel, DO, is the Assistant Professor of Physical Medicine and Rehabilitation and Oncology at Johns Hopkins University School of Medicine. As a clinician, she has expertise in cancer rehabilitation. Her primary research areas of interest include quality of life and function throughout the cancer continuum, the role of exercise in cancer prevention and treatment, prehabilitation, and lifestyle medicine. She completed her traditional osteopathic intern year in the Crozer system, and her interest in caring for cancer patients grew during her physical medicine and rehabilitation residency. She then completed her fellowship at the University of Texas, Maryland, Anderson Cancer Center. After her fellowship, she served as a staff physician at Adventist Healthcare Rehabilitation, where she focused on cancer rehabilitation. Since joining Johns Hopkins in 2018, she has expanded cancer rehabilitation services in Baltimore and the National Capital Area. She works with a multidisciplinary team to optimize quality of life and function in cancer survivors. And Dr. Engel, we're super excited to have you with us tonight, and I'm going to turn it over to you.
Thank you very much for having me. We are having some significant storms here, so hopefully I don't lose internet and or power. But we'll knock on wood, I guess that it works out okay. Thank you very much for having me. I know that many people have been affected by cancer and cancer-related fatigue, and it can be a huge burden. So I just wanted to acknowledge that because it's really hard. We don't have a specific, people always ask about pain. And for pain, we have pain medicine doctors. We have interventional pain doctors. We have going to the grocery store and seeing that there's an aisle that's dedicated to salves and sprays and patches and pills for pain that are over the counter. And there's all sorts of remedies behind the counter as well, acupuncture, et cetera. And people always ask about pain. For a while, it was called the fifth vital sign. And what we don't ask about a lot is fatigue. And so thank you very much for having me. So sorry, I just pushed too many buttons at once. I apologize. So I'm in the National Capital Region in Bethesda and DC at Sibley, as well as at the main campus for Hopkins. I don't have any disclosures. I just wanted to say that we could work in questions if you'd like. Unfortunately, the way I have it set up right now, I won't be able to see if you're asking a question, but it's something I could try to see if I can work it in, or we could do it later. There's many organizations such as Hope Connections, which I've had such great luck referring patients to, and they've had wonderful stories about different programs that they can be part of, both virtually and in person. There's other things like the YMCA as well, and Livestrong Foundation and Silver Sneakers. But thank you very much for doing all that you do with Hope Connections. So Randy Pausch, unfortunately, passed away from cancer many years ago. He was on Oprah when, Oprah had her show. And he was someone who was in Pittsburgh, and he had something called the last lecture. Apparently at Carnegie Mellon, I believe is where he was. They have something where if you know you're going to leave or retire, you have this big last lecture. And it ended up turning into a book. One of the quotes from it was, "We cannot change the cards we are dealt, just how we play the hand." And I thought that was very appropriate because unfortunately he did pass away from pancreatic cancer. And it's true. We never know what impairments we're going to face, what different issues we're going to face. We could only change how we deal with them. And so when I say survivor, it's definition of anyone who's been diagnosed through to the time of death. And we know that many patients with cancer are over 65 years old. And that there's millions and millions of people in the United States living with cancer, tens of millions. And cancer rehab aims to look at the whole person. We look at the physical impairments, the psychological impairments, functional, social, vocational, and we try to treat the whole person because we know it's more than just one thing to treat. What is physical medicine and rehab? it's easy to just say ortho, bones, fix bones, cardiology, heart.
Oh,
Physical medicine and rehab is a little bit of a longer speech, a longer elevator speech, I like to say. And so we're a little different than other medical specialties. So you might have heard us called rehab, physiatry, PM&R, physical medicine and rehab. And we don't necessarily look for a cure. We know that there's not going to be a cure for everything. We see patients with spinal cord injuries and amputations and multiple sclerosis and musculoskeletal issues. But our goal is to maximize independence in the patients, improve quality of life, and improve activities of daily living. Activities of daily living are things that we need to do, typically things like going to the bathroom, getting on and off the toilet, getting in and out of the shower or bathtub, washing our face, for example, or brushing one's teeth, eating and things like that. And if you ever have an illness or an injury that compromises that, it's a big deal. You don't realize until you're in those shoes, and until you have an issue. So as physiatrists, we work on designing a comprehensive, patient-centered, holistic approach, and we work with a team. We can't work by ourselves. We definitely need the assistance of oncology, radiation oncology, surgery, navigators, sometimes clergy members, nutrition, physical, occupational, speech therapy, pelvic floor therapy, aquatic therapy, and we try to make this very large team at times to have people that can help. And we use cutting edge technology as well as time-tested treatments to maximize function and quality of life in patients. Okay. So cancer rehab is rehab or medical care that can be done at any time throughout the cancer continuum. And we, as trained rehab professionals, we diagnose and treat patients' physical, psychological, and cognitive impairments to maintain or restore function, reduce the burden of the symptoms, maximize independence, and improve quality of life. And there's unfortunately a lot of folks that have not been fellowship trained, but there's some folks that have, some folks that haven't. I wish there were more cancer rehab docs in the country, but there's more than when I started, so that's good. And we focus on identifying, diagnosing, and treating cancer-related impairments using a rehab approach. And sometimes it might be something as simple as a lifestyle modification. Hey, maybe if we take the pills at night instead of in the morning, it might be a better improvement to your sleep, things like that. So sometimes I was trained in osteopathic medical school, so I'll use osteopathic treatment techniques at times, medications, injections, referrals to others. Cancer rehab really started in the 1940s. By Dr. Howard Rusk, and he was at NYU, and then Lyndon Johnson in the 60s said, hey, this is really important. We need this commission on cancer, heart disease, and stroke. MD Anderson started having physical medicine and rehab in the 60s. And then Dr. Rusk and Dr. Dietz were doing this at MD Anderson and Sloan Kettering in the 60s and 70s. It was not until 1989, though, that there was the cancer rehab special interest group that formed for my organization. So I guess that was probably during the Reagan administration. And then we started having more cancer rehab programs. And then finally, physical therapists had a certification just only in 2019. So we've been trying to, we're a newer emerging field that not everyone knows about. But we have different phases. We have the preventative. So we might anticipate that, hey, we know that when someone goes through cancer treatment, their level of function, unfortunately, is going to decline. That whether you're an elite athlete or a couch potato, that your level of function is going to decline from cancer and its treatments. And how do we prevent such a steep decline? And so we have this preventative section, a restorative, trying to return to your previous physical, psychosocial, vocational status, supportive, trying to, if there's something, for example, if someone has to have an amputation, to train to accommodate disabilities and minimize the impact of disease, and then the palliative part too, with symptom control and prevent and minimize complications and provide comfort. And we really put the patient and the family at the center. This is just an example of some of the people I work with, like nursing, therapy, consultants, support services. And we really have to keep the needs of the patient, the family, at the center. And going along with that, Atul Gawande wrote this book called Being Immortal: Illness, Medicine, and What Matters in the End. And he said, we've been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really it is larger than that, is to ensure well-being. And we know that well-being is helped to be promoted by rehab benefits. So what does rehab help with? It helps people be more mobile. It improves cognition because you're getting more blood flow to the brain. It helps with mood. It helps with social vulnerability. It helps people maintain those social contacts because maybe you can get out of the house because you're being more mobile, or have people over because you're more independent. It can actually help, and this is something I'll go into a little bit more later, people had better outcomes with their diseases. There's a study that came out in the New England Journal of Medicine last month about folks with colorectal cancer and how they actually did better if they were exercising. It can help with nutrition. It can help with energy and function. And also physical activity has been shown to help reduce and prevent multiple types of cancer, and probably even more cancers than we know about because they did specific studies with specific cancers. And so it's probably even a greater impact than we currently have knowledge about. And cancer rehab is unique because we do this holistic approach with the patient at the center, and we use our medical knowledge to consider the safety considerations. Sometimes people have low blood counts, or they have seizure precautions, spinal precautions because of a metastases, for example, in a bone. Or maybe they have different lines, ports, PICC lines, things like this. Different bandages or specific surgeries with range of motion restrictions. We use the rehab precautions. We screen for and address cancer and treatment-related side effects, and we use this multidisciplinary approach with the doctors, the therapists, physical, occupational, speech, aquatic therapy, pelvic floor therapy, whatever it may be, and we can treat any time throughout the cancer continuum. It's not just a one and done. When I see patients, I tend to see them for a prolonged period of time. And for some patients, that includes throughout the entirety of the rest of their life. And we look at the big picture. We don't just say, if you came to me and you had something that someone might consider small, like carpal tunnel syndrome, well, why did that happen? Do you have lymphedema and that's causing swelling in that area? Are you doing something differently because your muscle strength isn't the same as it once was? And maybe that's putting a lot of pressure on this area. It's not just I can't do an appointment in 5 minutes. It's not just an in and out scenario. We ask about the bigger picture. In fact, I tend to ask patients what's important for them. What does their life look like? What is their job? What are their hobbies? What does a typical day look like? How are they sleeping? To get the whole picture. And so sometimes when I ask patients about their hobbies, they'll be like, I'm sorry, did I just hear you right? Did you just ask if I have hobbies? Did you just ask if I have pets? Because it's important, right? And so those are things to talk about. And then we know, as being a cancer survivor, there are so many unmet issues. There's these unmet physical and psychological needs. Could be activities of daily living restrictions. There could be financial issues as well as relationship issues. And we're trying to help with all of those. There's a concept called prehabilitation. And what that means is trying to get there as soon as possible. I understand that having an appointment being told you have cancer, you need to do chemo and radiation and surgery. Oh, and by the way, do rehab is too much. So I don't think it needs to be done on the first day. But maybe, within the first 30 days or the first couple of weeks, this could be brought to the table. And what we're trying to do is find this opportunity to identify the baseline status and see if there's any pre-treatment impairments. If you hurt your shoulder years ago in the gym, that doesn't just magically go away when someone has cancer. Cancer doesn't occur in a vacuum. All these other pre-existing issues are going to be there. So can we work on the range of motion now in the shoulder before someone has surgery, for example, for breast cancer, before they have radiation, so they're able to get into position and stay in position? We try to improve the physical and emotional health before treatment or as early as possible, reduce treatment-related morbidity and mortality, decrease the length of the hospital stay and readmissions, and increase in available treatment options for patients who would not otherwise be candidates, and quickly facilitate return of patients to the highest level of function possible. And it's a process throughout the continuum of care that occurs between the time of diagnosis and beginning treatment. We look at physical, psychological assessments to establish a baseline function, identify any impairments, and provide targeted interventions that improve a patient's health to reduce the incidence and severity of current and future impairments. The number one goal of prehab is to prevent or reduce the severity of anticipated treatment-related impairments that may cause disability. And this is prehabilitation early. I don't know if you could see my mouse or not, but in the beginning, it's prehabilitation as close to diagnosis as possible, ideally before starting treatment. But I want to make this very clear. We do not want rehab in any way, shape, or form to delay someone getting treatment. It is very important for them to get treatment, and it could happen at the same time. We don't want it to delay treatment. If someone says to me, hey, I'm supposed to meet with you at 8 o'clock in the morning, but I have an appointment with my oncologist, I'm just going to push the oncologist back. I'll say no. Or I just have an infusion. I'll say no. Maybe I can come see you in an infusion, or we can work out another time. I don't want to delay anything with treatment. Then there's restorative rehab after prehab, supportive rehab, and palliative rehab, and throughout the continuum. And we know that the number of patients with cancer and survivors are going to continue to increase. And there's going to be early detection, improved diagnostic methods, more effective treatment, and improved clinical follow-up after initial treatment for cancer in aging populations. We'll see a number of cancer survivors. Additionally, sometimes we'll see patients that say, this is not my first cancer. This is my second, third, fourth cancer, be it from genetics or treatments that they had or something they were exposed to or just duration of time. I'm 90 something now, but decades ago I had X, Y, and Z cancer. So impairments can continue to build up. And we know that cancer and its treatments have side effects that alter quality of life. We know that it's a good time to refer to us if these things have happened. Hey, if someone was, oh my gosh, I'm late to the appointment, running in the first day I saw them, and all of a sudden now they're being pushed in a wheelchair, what happened? Did they have neuropathy and they couldn't feel where their feet were and they fell? Did they lose a whole bunch of weight and muscle mass and now have weakness? Those are really important things for me to look for and for loved ones to look for. Did someone come in originally and they had this kind of walking stick off to the side? They didn't really use it. It was kind of in this extra bag they brought just in case. And now they're needing a walker or a wheelchair. They needing more support. Well, what happened that they need this? Are they getting, is it just, do they have a stomach flu or what happened? Someone fell. That's really important. In the words of one of my mentors, you can't fall. You tell people that it doesn't work, but if someone had to fall, we have to figure out why. Is it someone's blood pressure too low? Have they lost weight and now maybe they need less blood pressure medication? Are they not getting enough to drink and eat because they don't feel well? Do they have neuropathy? What's going on? So we need to look into that. Need for a caregiver all of a sudden when someone was independent before, or they had a caregiver stop by a couple times a week, do the dishes, do the laundry, and clean up a little bit and make a couple meals, and now they're needing someone 24/7. Well, what happened? And then also if someone has some new issues that prevent them from returning to work or leisure activity, we want to help with that. I've had patients, for example, that drove as part of their job and had cancer, had neck cancer, and then were no longer able to turn the way they needed to, and we were able to help with that. If someone needs an increase in pain medication, we can also help with that. If someone has impaired cognition, and we're working on more screening tools. So there's a lot of patients that will report a lot of symptoms with cancer and cancer treatments. The number one that we see here is fatigue, and it was in 42 to 92%. I don't know what study said 42%, but I think they need to go back and look. because most people will say it's 100%. Insomnia, which is best friends with fatigue. A lot of people will say that they have trouble falling asleep, staying asleep, or both, or wake up too early. Cognitive impairments, brain fog, we hear about a lot, chemo brain, chemo fog, depression, and these things are all tied together, right? Difficulty with eating, pain, constipation, shortness of breath, nausea, dry mouth, numbness, tingling, dizziness. And we know that the fatigue is a huge problem. And we know that there's this other issue that happens where they with having cancer, there may be a time where you quote unquote ring the bell, or you're done with treatment, you're done with radiation, you're done with your chemotherapy or whatever it may be. And it's not that you ring the bell and you're 100%. It's not that you were working 80 hours a week before you had cancer and now you can go back to working 80 hours a week the next day. 80 hours a week is tough for anyone. And we're not getting any younger, so that's a big deal. And sometimes that's something that I see and talk about expectations. But we know that the side effects of cancer do not end with the last treatment. We know that sometimes things can come up 5, 10, 20, even 40 years later, decades and decades later, from things like radiation. And we know that those are impairments that the cancer rehab docs can help with. Cancer rehab docs, I think we're basically all of us are at major centers right now. We are in places like Texas. There's actually quite a few in Texas. There's some in San Antonio. There's some in Dallas. There's some in MD Anderson in Houston and TIER in Houston, in New York and California. I don't know anyone that's specifically in a rural area at this point in time. However, virtual medicine has been extremely helpful in meeting people where they are. I have patients that are, live in, maybe a beach house on the Eastern Shore for the summer and don't want to have to come back for their appointments or not feeling well, or they live in maybe a rural area of Maryland or something like that too. And so that, that some people have more, I do have more than one state license. And so they're able to help people in other areas. Some people even have, I think someone even has an Alaska license, and some more rural areas. We have docs also in Seattle, for example. So we want to be able to help. And I should also say that it can be extremely anxiety provoking after the last treatment, because now what? Now the meal train might stop that someone had created because that was your last chemo. Now you're not seeing your oncologist as much or your radiation oncologist as much. And is this an ache or pain from carrying groceries that were too heavy, or is this cancer that's causing my back to feel this way? And so it could be it's a huge transition in your schedule and life. And so what do we do from here? And a lot of people continue to have cancer related fatigue. You could have it before your treatments, during your treatments, after. But cancer related fatigue is a distressing, persistent, subjective sense of physical, emotional, and or cognitive tiredness or exhaustion that is related to cancer treatment that is not proportional to recent activity and interferes with usual function. So sometimes people will say, hey, I just, I slept 12 hours and I woke up feeling like junk. I would have, I couldn't believe it. And so, or, I took a nap and I still feel awful, or I just can't feel less tired. And so what some people will say is that the cancer related fatigue, those numbers are wrong. A lot of people will say, and that it's actually underreported, underdiagnosed, and undertreated, that it might be over 80%, it could even be 100%. And the symptoms may last days, weeks, months, years after treatment. And it's extremely common. Probably, most people that have had cancer have cancer on this Zoom right now, or loved ones have talked about this, and it really can cause a lot of distress, and it's hard to really describe to someone what it feels like. Some people will say, oh yeah, I know you're tired. I get it. You're tired. I didn't sleep well last night. My neighbor's car alarm was going off, and I get it, but it's different. It's very, 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 very different. Or they'll say, you know, I had the flu before. I can imagine what it feels like. No, it's not good. It really does not. It's very, very, very tired, and very, very fatigued. And there's things that you probably want to do and are not able to do. And that really can cause a lot of distress. It's very hard for someone to really understand what you're going through. And that can really alter your quality of life. So I'll ask patients what a typical day looks like for them. When do they get up? What do they eat? What do they drink? When do they eat? When do they drink? What activities do they do? Are they working? When do they go to sleep? When do they go up to bed? And when do they actually go to sleep? What do they do between now and then? A lot of us during COVID got in the habit of doing things in our bedroom that maybe we shouldn't have. Playing games like Wordle, you know, all these different things, or you know, doing Zooms from our bedroom, and talking to your friend from college, was in a different time zone or something, folding the laundry there or using it as an office. And that's not what our brains really want. We are creatures of habit. We want to associate the bedroom with sleep and sex, and that's it. Not staying up, not painting your nails, not watching reruns of some show on that you're streaming. It's really supposed to just be for sleep and sex, not as a platform for folding laundry or anything. And so we have to sometimes break some of those habits, and that can help for some people. But there's so many things that could be components of cancer-related fatigue. Anemia, low blood counts, they don't help. Sometimes people have vitamin deficiencies they don't know about. Things like vitamin D, B12, huge impact, huge on energy and fatigue. And that's not something that's typically assessed or tested for on the usual blood tests. You have to, it's in a separate section when you're ordering it. It's not, the CBC or complete blood count and the basic metabolic panel are usually checked for, but these are some extra things. So it's not, if you go to the ER because you broke your ankle, they're not going to check your B12 level. They're not going to check your vitamin D level, right? So these are things that are separate tests and there's some others that we sometimes have to look into. And sometimes it's like a quick fix, with that. Or electrolytes too, if they're off, can cause issues. Sleep disturbances. So many of us have sleep apnea and don't know it. I mean, I could tell you that my partner snores, but I don't know if I snore or not. And so sometimes that can contribute to things like sleep apnea or sleep disturbances. Other issues going on, if someone's thyroid's not working up to par, they can have sleep issues too, and fatigue. And so those are all things we need to look into. And then sometimes coping mechanisms like that are not so helpful and are actually very harmful, such as alcohol abuse and substance use, can really contribute to fatigue as well. Cognitive impairment is also part of it. Hormone imbalances, dehydration. Hormones are thinking more like thyroid hormones, dehydration. It is warm outside, everyone. You need to drink enough water. We don't want anyone passing out because their blood pressure goes too low or dehydrated. And make sure you have an emergency bottle of water with you, because you never know, you could get stuck in a traffic buildup when it's raining like this, or some other issue, and it's good to just to have a bottle of water just in case. Pain can really contribute to fatigue, and pain has to be addressed, and there are so many different ways to address it. Treatment-related side effects can cause fatigue. Cancer itself, pre-existing conditions, deconditioning, emotional distress, and infections. Someone can have a urinary tract infection. So we have to make sure we're asking the right questions. This is an example of a fatigue scale that's this little jelly bean guy. It's 0 fatigue. So I'll say on a scale of 0 to 10, how bad is your fatigue? So 10 to me is falling asleep standing up. But in this case, it's falling asleep on an office chair, which I could argue sometimes people could probably do that, not be a 10. But falling asleep standing up would be 10, and 0 is like, hey, he wants to be able to go out and play a soccer game, or he could jog with a little bit of fatigue, but just walking is going to get very tiring at 5, and he just wants to kind of sit in a chair and I guess probably watch the television at 8. So This is supposed to be the fatigue cloud, and there's different strategies of managing this, right? As I already alluded to earlier, physical activity can help tremendously with fatigue in most cases. If you're already exercising, continue to. You don't want to stop because you were diagnosed with cancer. You want to do whatever works for you, whether that's walking around your house, walking around the block, walking in the mall, whatever works. And you want to monitor your own fatigue levels. Consider distractions like socializing, Zoom with your friends, not in the bedroom, games, seeing family and friends. You want to make your interactions meaningful, though. You don't have to make this like full dance card. You want to, you want to use your energy effectively. Again, we like routines, and you might want to set priorities and make your expectations reasonable and realistic. Um, Rome was not built in a day. Not everything has to be done at once. I've tried this before. If you leave the dirty dishes because you're tired, they will still be there the next day. So, and you could do things like sitting down to fold laundry and to try to make conserve your energy by pacing yourself. We're hearing more and more about pacing now, I think since COVID. But you want to pace yourself. You don't want to just try to get it all done in one day. Spread things out, do things when you have more energy. Know that if you do a lot, you've a family wedding in town or something like that, you're going to be more tired. And try to do things too. Like if you know you don't have as much energy and you have to get together with a group of people, maybe you shouldn't be hosting dinner at your house. Or, you know, maybe look into carry out if it's possible to have people at your house and I don't know, paper products or something, but or see if someone else can do it. Do one thing at a time. Multitasking is actually really hard on the brain and we're not good at it. Um, and then you could look at ergonomic and assistive devices to make life easier. You actually want to limit your naps because that can kind of interfere with your sleep schedule. If you take a nap too close to bedtime, um, and if you take too many naps, then you're not gonna be tired at night. Then you're just, you're gonna want to look at your phone when you're in bed because you can't go to sleep. Don't overdo it. You could delegate tasks, complete activities when you have the most amount of energy, postpone the non-essentials, and then use technology to your advantage. You could set up reminders for things if you're having cognitive fatigue on your phone. You can dictate now instead of typing, which is great for some people. You really use the technology to your advantage. And go outside too when you can, because that's also very helpful. So what tools do we have? Physical activity exercise programs, cardiovascular and weightlifting programs, rehab referrals. Cognitive behavioral therapy can be very, 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 very helpful for insomnia. Support groups, journaling, mindfulness. There's many programs that Hope Connections has, for example, that you can look into. I don't have the current flyer in front of me. I apologize, but I did look at the PDF earlier for July, August, and September, and there are a lot of different programs, and you can even do them virtually, so you don't have to worry about using that extra energy to go somewhere, getting changed, sitting in the traffic, parking, bringing water or snacks with you, and do you have your, your wallet and all those things. You just turn on the computer screen, and if it's not for you, it's not your cup of tea, you just turn it off. So this could be helpful. Nutrition can be very helpful. There's something else called bright white light therapy, which is a tongue twister, but also it is a very bright light that basically people put their face in this like light box early in the morning, and it's supposed to help with fatigue, massage therapy, yoga, acupuncture, sleep hygiene. And again, unlike bed knobs and broomsticks, the bed is only for sex and sleeping, and making a sleep routine. Don't think like, oh my gosh, I'm going to do a million things and then I'm going to go to bed at 9 and by 9:03 I'm going to be asleep. Unlikely, very unlikely. You have to kind of wind down at the end of the day. Use less screen time. Don't do something very stimulating before you go to bed. Don't think like, hey, I'm going to, watch the Ozarks or some sort of really thrilling show or whatever that may be, Die Hard the movie or something. I don't know. Just don't watch something really thrilling because you got to have to like kind of tone it down as the day goes on. Maybe you shouldn't have bright lights, on at 11 o'clock at night. And so you kind of want to, have these sleep routines. Some people will use a sound machine, because it creates kind of like most of them like a white noise. And then, because it's the interruptions, that actually can wake you up. So if you hear, something fall off the shelf, your cat knocks, 'cause cats are the ones that do this, knock something off the shelf, that might wake you up. But if it's this white noise in the background, or this continuous noise, then it usually can overshadow that. Sometimes people need medical interventions. They need their medications at a different time, a different drug in that class. Sometimes people, need help going to sleep. Sometimes people need something like psychostimulants such as methylphenidate. You want to treat any, or I want to, the docs want to treat any impairments that are causing the fatigue. Sometimes supportive care or palliative care can be very helpful. Integrative medicine is really helpful too. Cancer rehab, tweeting my own horn, psychiatry, psychology, and specialists. And then we know, again, this is a big group of papers that were released in the fall of 2019, but from the American College of Sports Medicine. And they said being physically active is one of the most important steps for people of all ages and abilities that you can take to prevent cancer, and prevent abilities can take for cancer prevention, treatment, and control. And you want to consider also that there's a lot of side effects. A lot of these medications that we use in the realm of the cancer realm, like sometimes steroids, woof, they can keep you up at night. They can give you the energy at one point in the day, but they can keep you up at night. And so should we maybe be taking them earlier in the day? Probably for most folks. There's some other, some of the anti-nausea medicines, very fatiguing. Is there something else that we can use instead, or something else that we could do instead? So this American College of Sports Medicine had these 3 papers that came out, and one of them was called Exercise is Medicine. We've had even a better paper come out, although it didn't apply to as many, or better evidence, I should say, for at least colorectal cancer. The people that did exercise did even better with treatment. And so it's saying, basically that sitting is the new smoking, that unfortunately you want to sit as little as possible, move around more, take breaks, and from sitting, and move around. You want to have at least 150 minutes of aerobic activity per week. Excuse me. You can add vigorous activity in there as well. What is moderate aerobic exercise? So you can talk to someone, but not sing. So if you sing, that's more air that you have, and you're probably not, you're not at moderate level. Vigorous is, it's a little hard to talk. So, it's so moderate, and that might change on the day depending on how you're feeling with treatment and things like that. But they want you to have moderate aerobic activity and at least 2 resistance exercise per week. And they found that people that exercise during and following cancer treatment, that you can have improved cancer-related fatigue, health-related quality of life, physical function, anxiety, mental health is improved, such as depression, sleep, lymphedema, and bone health. And they did not have different recommendations actually than people that didn't have cancer. They are still saying the 150 minutes of aerobic activity of moderate intensity a week for folks that do not have cancer. So that's good to know. And then this is a little bit more about the recommendations, to have at least moderate intensity aerobic training at least 3 times per week, at least 30 minutes at a time, and at least for 8 to 12 weeks. The addition of resistance training to aerobic training at least 2 times per week is important too. And then increased sitting was not good. And the elephant in the room is that the #1 cause of death in the United States is actually cardiovascular disease. And so for folks, this is a big deal. And trying to prevent cardiovascular disease can be achieved through exercise. Exercising before one was diagnosed with cancer was great. That's good. Lower colon cancer mortality, but actually exercising after a diagnosis has the greatest influence on the outcomes. So I'm going to look at actually the chat box. I haven't looked at it yet. Okay. And then I'll go into the next part. Oops, so sorry. Let's see. So someone wrote that even though they're fatigued, they have greater difficulty sleeping at night, no matter what you do, and they've tried many things. That can happen. And I would say that some of the biggest things to try are to try to change your habits, to try to wind down at the end of the day and try to only use the bedroom for sleep and sex if at all possible. There are medications that sometimes we need to use, or supplements that sometimes we need to use. Sometimes people do need to do acupuncture. You have to also, sometimes people, if they do physical activity too close to the bed time, it actually can wake you up, and you have to be careful with that. But cognitive behavioral therapy would probably be like the next step. Then I think I'll wait on some of these. Okay. So, lifestyle medicine is something else that I started practicing and studying a little bit ago. During COVID, I just kind of fell into it, although it probably should have been something that we should all been practicing for a really long time, because it includes, right now, there are 6 pillars. They're probably in the future going to add another one about being outside in nature or something along those lines that sounds more eloquent than the way I just said it, but it's to avoid risky substances and behaviors, right? So you should be wearing your seatbelt when you drive. You should not be having too much, too many beverages that contain alcohol or street drugs or anything like that, or tobacco products. It includes stress management, and this is huge. Being part of the cancer rehab community, we see, it's extremely stressful with cancer. When is there going to be recurrence? Is there going to be recurrence? What would a recurrence look like? What is this? What is that? It's really hard. What is going to happen? I have a scan coming up. What do I do to get through the scan? And so we could work on stress management. And then if something that, sometimes we do need the assistance of our colleagues, social workers, psychologists, psychiatry, therapists, and things, and additional folks like that to help in that arena. But we will work on things like birthday candle breathing, where you imagine you're in this great, amazing place. You have all your favorite people there for your birthday. You don't have to invite the people you don't want. They could be living or dead, and you imagine this room of people, and you're in front of your favorite kind of cake with no calories, and you're about to blow out the candles, and you take a very deep breath in, and then a long, slow breath out to blow out all those candles. And that is very, very helpful in resetting the nervous system. And so that can be very helpful for stress management. We obviously need a little bit of stress in our lives. That was a holdover from evolution. If you're being chased by a bear or a shark or something, had to get away quickly. But there's things that happen, anxiety producing in our life. There's things that are stressful in our life that we want to definitely, bring our nervous system back to normal as soon as possible. And when, if someone cuts you off when you're driving on 95 or something like that, and this breathing technique can help very, very quickly. Social connection is so important. Loneliness is a huge, huge, huge problem in this country. It's an epidemic, and it's very, 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 very hard to do things alone, and to be going through this alone is just, it's very, very difficult. And so social connections, whether it be someone that's, a neighbor, a friend, family, someone in your house of worship, is very, very important. And then there's a lot of support groups that I know we have through Hopkins, as well as through Hope Connections, that could be very important. And it can be something to do with a specific type of cancer you have, or something else that's completely different in making those connections. There's meetup groups, there's groups through different social networks now, virtual and in person. If it might be a book club, or so many different things. The world's kind of your oyster with this. Physical activity, I said it again, is really, really important. Nutrition is important as well. And we work a lot with our nutritionists and restorative sleep. And so these are the 6 pillars of precision medicine. And I think it's time for us to change our thinking in the medical community that when there's a lot of opportunities for rehabilitation, especially if people are getting things like neoadjuvant treatment, and rehabilitation can be multimodal, working on mind, body, spirit, to kind of also talk about expectations, what does it look like, what would be next. And you know, talk to people about how they're sleeping, because unfortunately a lot of people are not sleeping well, and incorporating lifestyle medicine is really helpful as well. And I know that I'm practicing lifestyle medicine with patients with cancer, and we're trying to increase and get more people practicing in Hopkins, and there's some people elsewhere, for example at GW, that are practicing lifestyle medicine. It could be very, very helpful at looking at someone as a whole and looking at these 6 pillars by which we should be leading our lives. And I think that's it. So